I don't manage to, oops, sorry. I don't manage to open the chat. Why is that? Okay. Otherwise, Tatiana, okay. Thank you. I just needed to get an okay. I don't know if Tatiana can send me the okay to start, because I can't open the chat message this time. I don't know why. Okay. No. I see. Okay, perfect. Are you well? Good. Maybe that was on your control. So if you can just confirm that I can start, then I'm ready. Let's go. Thank you very much. So I close down the chat and I wait for you to release okay. Good. 1, 2, 3. Welcome, everyone. This is Didier Dieci speaking from Geneva in Switzerland. I would like to welcome you to this third part of our webinar series on the interceptive and ultra-conservative treatment of tooth wear. We had the first part, which was dedicated to diagnosis, risk factors, and modern treatment strategies. And you certainly remember that basically our overall approach involves 3 possible strategies: preventive, interceptive for moderate tooth wear cases, and what I call restorative for more severe tooth wear cases. And of course, the preventive measures are to be added for any interceptive or restorative treatment. The second part was dedicated to direct interceptive treatment strategies and clinical protocols. So that was really a step-by-step description of the interceptive treatment protocol, but somehow the treatment planning follows the same approach, whether you go with interceptive strategy or restorative strategy. And the third part, which is right now, is about indirect and hybrid treatment strategies and clinical protocol. I was missing time for the second part to show you a full molded case. And I will use a little part of the third module, the third webinar, to introduce this full molding technique, because I think it might be of interest for the audience. So let's go through a full molding case. I finished the second part with some recommendations in regard to the use of reference points. Those reference points are needed, either the proximal contact and the marginal ridges and the central grooves, to guide the sculpting in case you go with a freehand approach, or for the molding to stabilize the index. If you get a little more advanced tooth wear, what we call moderate tooth wear, you still want to get intact proximal contacts and probably the end of the grooves, the occlusal grooves, to stabilize your index and basically to be able to restore the original anatomy in a proper way. And then, of course, the anatomy this time, instead of being just freehand molded, will be basically controlled by an index, the index being made from the wax up. So that is actually a simplification to transfer the new video, which you have established with your wax up, into the mouth, because that has been considered very often as a difficult situation. If you're very experienced with direct restorations, with sculpting composite, you might find it relatively easy, but not everyone is doing this every day. And that's why we have developed these molding techniques. There are two types of molding techniques, even three, but I would like to concentrate on those first two molding techniques, which is the partial molding. It means we only mold the facial and lingual cusps. So we cut the index in the middle. This is what we do when we don't have such a perfect wax up. If your wax up isn't done in a perfect way, that might be a better strategy. And when you have an excellent wax up, then we do a full molding, but not full molding tooth by tooth. That also exists, but I think it's a little overcomplicated and time consuming, and maybe not as precise as the full molding, which is a direct transfer from the wax up to the mouth, but I would like to show you how it works. So I will use a hybrid case to illustrate this technique, this treatment modality. A hybrid case in terms of risk factors. You see, for instance, on the upper front teeth, the facial anatomy has been lost due to obvious erosion. You also have signs of erosion on the cervical areas, not only on the front teeth, but also on the lateral teeth. Some of them were already restored. And you can see here in these cervical lesions, probably a combination of erosion, abfraction, and attrition. And on the lower front teeth, severe attrition. Note that on this image, the canines were already restored with composites to recreate canine guidance. So it's a little bit further during the treatment. You have seen the signs of attrition. Now, if you look at the pre-treatment view on the upper arch, you see that the occlusal anatomy of part of your teeth is nearly intact, which is quite difficult to understand. Due to the fact that we know the patient is suffering from bruxism, awake and sleep bruxism, she's reporting tensions, and the fact that she's biting with a lot of force on her teeth during the day, but not doing excursive movements. So she has clenching. This is more typical for awake bruxism, and sleep bruxism with wider, broader excursive movements, which actually are responsible for the destruction of the upper front teeth. If you look at the lower back teeth, we have some flattening of the cusps. You will see on the details of these areas a little bit later that we also have some fractures, not only wear facets, but fractures of marginal ridges. So you might think, but the clenching thing, how can you demonstrate this? In fact, if you look at the Nygaard, this is a Michigan type Nygaard. Look at the indentations on all the teeth. So you see on the front part, you see the broader excursive movements, but you also see relatively marked wear facets on molars and premolars, which is typical from basically clenching. So even probably during the night, because the patient doesn't wear that kind of night guard during the day, obviously not, it means that she has periods of clenching and periods of bruxism. Tooth wear is a multifaceted type of pathology. Erosion, attrition, parafunctional movements are different from one patient to another, from certain times of the day to another. They are rarely symmetrical. So it's complex by nature, and that's making this pathology very interesting to treat. So the treatment plan has been done on models with classical analog wax up. So we have decided to build up the vertical dimension of occlusion in order to create the space to restore the upper and the lower front teeth. So now you see an occlusion or approach to this case, and everything will be done with a direct approach, but molded. Why direct? It's moderate. We might Discuss eventually the option of using ceramic veneers for the upper front, but here for financial reasons, we decided to do everything direct. We did a mock-up, very simple, a little bit primitive here, just with bis-acryl material that we use for temporaries, only to check the tooth display and the proportions. The patient didn't like the teeth to be longer, so we maintained that length as our reference for the future restorations. We checked also from a lateral perspective. We try also to find the best compromise in terms of tooth display, overbite, overjet, increasing the video with us losing anterior guidance and canine guidance. So all these must be evaluated in a proper way. And this is why actually we like to have the lab step defining precisely the amount of augmentation for the video and the anatomy of the teeth, as we should replicate them with the molding technique. So now you see more details about the lower left quadrant on the rubber dam ready to be restored. You see the more severe indentations on certain areas, especially the molars, much less on the premolars. This kind of lesion is due to clenching. You don't get that kind of lesion with us clenching. With bruxism, the front teeth, they are basically creating a disclusion, at least at the beginning, and it's very difficult to break marginal ridges if you only brux. It's more probably clenching here. This is the tray which we use for the full molding. It's a hard tray, 2 millimeter thick, that basically will be relined with translucent silicone material. You will see that on the video, which is coming in a few seconds. We have used Teflon tape to fill up the interproximal contact so that the composite doesn't come below the contact. You see that the tray is opened. Maybe let me open the laser pointer. You see here that the embrasures are accessible to remove the excesses of composite. And this is the situation after removing the composite. We, of course, do not etch the entire anatomy so that the excesses which you see here on the image are easy to remove because they are not sticking to the surface, the enamel surface, because it was not etched. So that's now the occlusal view, just after removing the index. We go with a combination of a number 12 blade, discs, and fine diamonds, normally a flame shape. And when we have cleaned the margins, we can go with a rebonding and characterization using some effect shades. We love to do that. We love to give those restorations a more natural look. Wow. Be careful in women patients. Do not exaggerate the amount of colorant because they might dislike the appearance of a heavily stained occlusal groove. So we need to do it in a very discreet way. But this is somehow like art. We like to paint. It is really the only thing which remains from, let's say, some artistic procedures in dentistry. You see now on the right side that tooth wear is less than on the left side. That's very often the case because parafunctional activities are not symmetrical. Normally, you very often observe that there are preferential contacts on the left, on the right side, sometimes more protrusive, sometimes a little bit more lateral. Parafunctional movements are not symmetrical by nature. So here we have some wear facets on the premolars, but the severity of wear, tooth wear here is less than on the other side. But anyway, we need to increase the video in order to create the space to restore the front teeth. Lower incisal edges, upper incisal edges, and palatal surfaces. This is after staining and cleaning Very simple, very efficient technique. So now I would like to illustrate the technique with very short video, but it summarizes the steps. We have taken the wax away from the incisors and the distal buccal cusp before duplicating the model. Now this is a duplicate which will serve to fabricate those trays. You could even do a single tray and cut it in the middle. You don't even need to use all the fronties as a initial stop. Second step, which I've performed myself here, which is normally done by the lab, is to open up the embrasures to facilitate the removal of excesses so that every critical area is easily accessible. This is the Memosil, this translucent silicone or something similar. And we use the wax up to reline the tray. The tray has been sandblasted. You can also use an adhesive for silicone impression materials. Make sure that the Memosil stays inside the index. You wait normally 1 minute, and then you can remove the excesses of silicone. And normally after 2 minutes, 3 minutes maximum, you have a perfect index replicating all the details of the wax up. Preparation is only sandblasting, as I said in the second part of this webinar serial. We also clean the proximal. You remember it was some small fractures, especially on the left side. So we clean the embrasures. Then we proceed with adhesion. I love to use a 3-step etch and rinse, which is the Optibone FL in this case. So I go with the primer on dentin, you dry, then you go with the bonding and you lacquer. Then we'll try the tray, make sure that it goes in place, especially where you have clamp. Then I use some Teflon tape to fill up interproximal spaces. And also I use isolation material called Rubicep to isolate the contacts so that the composite doesn't go inside the contact. Here you see that the composite has been placed on the teeth. That was only for the video. Normally we can place it, it's even easier, inside the tray, and then you bring the tray in the mouth. It takes a little while until the tray comes in its final position. Take away, of course, the excesses of composite before lacquering. But the molding step itself takes a couple of minutes, 2 or 3 minutes. The preparation of the tray, of the index, that's normally all done by the lab. So there isn't much work to do when it comes to the molding. So you have seen the number 12 blade. Now we are going with discs to finalize the cleaning. And the last step is fine flame, 40 microns. And when it's done, I clean the surface with my rebonding material, which is a self-etching adhesive, before placing the fissures colorant and a little bit of white effect shade. And this is the final arch after molding. So that is a very short version that I have implemented here in this presentation, because I didn't want to take too much time on the indirect protocols. But I thought you might like, let's say, this additional procedure, because I know that not everyone feels 100% comfortable with the freehand approach, because it is a little tricky if you don't have really enough experience with these techniques. So this is the final view of the lower arch after the full molding. And it's already here after, in fact, the completed treatment. But I would like now to show you what we did in the anterior area. First, on the lower, we have the index giving us basically the space which was defined by the wax up for leveling up the inside the ledges on the lower front teeth. That was done with direct composite using the index. So it's also a molding technique. We only mold, in this case, the lingual, not, of course, the facial. On the upper fronties, we decided to go with the full molding technique, both on the edge and on the palatal. This is one of the many options. You can go freehand, you can go with molding, you can go with indirect composite, you can go with CAD/CAM composite. There are many different options, but I would say that for moderate tooth wear cases, the freehand or the direct molding works very well. I personally reserve the indirect approach, or using CAD/CAM composite to build up the palatal only for more severe tooth wear cases. And you will see some other cases where I used sort of 360 lithium disilicate veneers, because at a certain moment it is a lot simpler and also cost-effective compared to a double veneering technique, even though there is a rationale to use composite on the palatal if you have used composite everywhere else. So here you see the material into the index. You need to get an index that separates the teeth in a proper way so that you don't build up too much composite inside the interproximal spaces. Here I used two different techniques because there is always a debate whether we should use dentine or enamel, whatever. On one side I used enamel, on one side I used dentine. But if you use dentine to build up the palatal and the incisal edges, as you can see here, you need to shape the lobes, the mamelons, so that you create the space for your enamel layer. You see here, after application of Azure effect, it is an effect shade that will enhance the opalescence of the incisal edges. That gives a little bit more depth to those restorations because we'll have a relatively large amount of composite at the end. And now you see the difference. Right side, enamel, so the enamel layer goes all the way to the edge. Dentine approach, it maintains the space which we need for the enamel buildup. And you see the amount of vertical augmentation, addition of composite that has been planned with the wax up. Now this is the final view. I did some extra veneering work because you might have seen that the incisal edges were a little bit thicker. We had some facial erosion. So I pushed the enamel a little bit further toward the cervical in order to cover completely the facial aspect of those teeth. So now you see the view, the lateral views on the right and the left side. There is only one tooth where we haven't replaced immediately the cervical restorations, which was made not such a long time ago. So this was the pre-treatment view with this combined type of erosion pathology, wear pathology with erosion and attrition. And this is the final view after full molding for the posterior, inferior posterior areas, partial molding on the lower front and upper fronties, molding the lingual and the incisal edge on the lower arch, and palatal and incisal edge on the upper fronties. I think it's a nice case. Of course, it's a very cost-effective approach. It would have been here probably an indication for ceramic veneers for the upper front, but as said, we had financial limitations and we decided to go only with composite. But that's an example of what is possible to perform with composite. We are 1.5 years later here. You see that the class 5 is aging here, so it will be replaced a little bit later in time. No change on the posterior surfaces, either on the upper because it was no restoration, but even on the lower after 1.5 years, Of course, we don't expect anything to change. This is 3 years later. We only observed a little crack here. It might have been a little bubble in the composite. If we look here at the lateral views, there is a little irregularity here and a micro crack here, micro chipping. I've made the pictures before cleaning. I had to do a real polish here, but when I do post-op images, what I show as post-op is always with no intervention, because otherwise it's not very useful to see a situation that has been improved after polishing, repairing, whatsoever. We want to see how it looks like with no intervention. That's the way we can learn from the behavior of those restorations. So I think that was an interesting protocol to be presented before what is the main focus of this third part, which is the hybrid approach using indirect and direct restorations. And then you will have a last case with 20-year follow-up. So the story starts with what seems to be initially a simple case. So this patient is coming and requesting the replacement of her upper front teeth, which she finds not aesthetic anymore. She doesn't like the relatively short front or short central incisors. She doesn't like anymore the round form of those teeth, so she asked for a replacement of the upper front 3/4 crowns. She had them for about 10 years. We have a slight palatal inclination of those teeth, and you might start to foresee or see some tooth wear on the lower premolars. But now, if we look to the front teeth with slightly opened position, you see the problem. We have supra-eruption of the lower front teeth. Is it the result of tooth wear? Was it a pre-existing anatomy? It's very difficult to say at this point, but you see the relatively important wear of the lower front teeth. And if you look carefully, we also have very flat anatomy on the cusps on both sides. So it looks like the case might not be as simple as we anticipated. If we look at the upper back teeth, there are minor signs of erosion, but relatively little attrition. We have a little more signs of attrition, as we have seen from the frontal views. Very often the occlusal views don't reveal always the consequences of attrition. You see the wear facets. There is more wear facets on this side and more depends. Some teeth got more exposed to attrition than others. As I said before, attrition is rarely symmetrical. Now we see the details. You see the wear facets. Those are, in fact, small ceramic inlays and onlays. There is a little bit less wear on this side, a little bit more on this side with exposed dentin here. On the upper, minimal erosion and attrition. Maybe here you see that the enamel is getting a little bit thinner, but I don't think at this stage we need to address this problem. We'll concentrate in regard to changing the vertical dimension on the lower front piece and the anterior areas. We have a slight additional problem with the asymmetrical gingival profile on the upper left. We have some recession. We have an asymmetrical position of the upper left teeth apart from the central incisors. We do our DSD analysis. We have a slight misalignment between the face midline and the smile midline, but it's about 2 millimeters. So that is something that is not critical from an aesthetic standpoint. As you might see already, we have an asymmetrical occlusal plane. We have a canted occlusal plane, what we will see in more details now. So now I'd like to go through our aesthetic and anatomical and functional analysis. Now I have centered this smile image and aligned it to the bipupillary plane. You see first the asymmetrical position between canines. The upper left canine is a lot higher than the right one. We have, by chance, at least centrals, which have gingival profiles symmetrical. And we have also some significant asymmetry and recession on the upper left lateral. So we have problems with pink aesthetics, and we have a few problems also with white aesthetics. Centrals are well aligned. We have a slight discrepancy between inside the ledge position of laterals, and even more pronounced between canines, but this is quite logical due to the asymmetrical vertical position of both canines. And we also have an inclined occlusal plane. You see that we have at least 3 millimeters, roughly 3 millimeters difference in the position of facial tips for premolars. So we try to address these asymmetries at the time. We'll build up basically the corridors. We have also this important supra-eruption of the lower front teeth, which we will correct by intruding the anterior teeth and correcting by additive procedures the premolars and the molars. So it's going to be a combination of orthodontic movement and additive procedures on the premolars and molars. So that is at the end of the Invisalign phase. We have partially corrected the position of lower front teeth because we need to integrate the future corrections made with the restorative material. Now you can assess a little bit better the wear which we have on the buccal cusps of molars. It's not extreme tooth wear, but it's important, significant enough to be addressed. So Invisalign has been used for this orthodontic correction. Invisalign is an effective method for intrusion, not so much for extrusion, but when you need to do an intrusion, Invisalign works relatively well. We made some DSD, especially to evaluate the amount of changes to be done here in regard to the gingival profile, but that will be part of the last phase, treatment phase. So this is our DSD. So we know we need to correct the gingival profile on both upper left lateral and canines. We'll also need to increase a little bit the volume because premolars and upper first molars are slightly tilted toward the palatal. They have a palatal inclination, and we have sort of empty corridors. We might maybe reduce a little bit the volume of canines, but it seems that that will not be enough to be able to realign the facial surfaces. So that is the final treatment plan or the updated treatment plan after doing the orthodontic correction. According to the wax up, this is the amount of video augmentation that we have planned. So it gives us a good estimate of how much space we have to restore the posterior teeth. We'll need to do little corrections on the upper, but that will be minimal, mainly replacing the existing restorations. And the rest of the space we'll use to recreate the anatomy of the lower back teeth. So now let's go through the detailed treatment for the posterior areas. We used the direct technique for the upper arch. And as I said, the main correction here was in fact replacing the existing restorations. We used a direct approach with the natural layering concept, a layer of dentin, layer of enamel, and characterization of the occlusal anatomy with effect shades. Same on the upper right side. Those are very small composite restorations. It's something very easy to perform. This is after completing this very simple restorative work. But here we wanted to get really to refresh all the existing restorations, because I found out that in fact adhesive procedures were apparently not done in a proper way, because as soon as you will touch the restorations, you will see that adhesion was not performed in a good way. So it was safer here to replace even small direct restorations. So that's now the post-treatment situation on the upper posterior teeth. What about the lower? There were signs of clenching. I had some cracks in the teeth, as you will see in a short moment. And a protocol that I've used very often, and that I use more and more when I have signs of clenching, is to stabilize occlusion where we have the highest functional forces. If there is one area where the composite might not work as well as we need, is for clenches, when we have anyway not so much space to restore the posterior teeth. So here, using lithium disilicate with a minimum thickness of 1 millimeter is one of my preferred protocols, but not for the other teeth. You see here on the side of the small inlays, you see that we have cracks. That's probably due to previous amalgam restorations, I do assume. Otherwise, even if adhesion was not performed in a very good way, there is no reason we would have mesodistal cracks around adhesive restorations. So I will seal the cracks with my multifunctional adhesive, 3-step etch and rinse. I will also use a very thin layer of flow to complete the sealing. And then I use a high E-modulus, relatively stiff material. Here, this is the Inspiral from Edelweiss. That is having a stiffness very close to dentin. And on top of it, I will have my lithium disilicate overlays, which E-modulus is relatively close to enamel. So I use a stiffer material on the surface, a little bit softer, so to speak, material underneath. It's a real biomimetic concept, using a material with similar mechanical properties or biomechanical properties to dentin for the first layer, and then a material having biomechanical behavior close to enamel. We honestly don't have by today a lot of evidence that this is imperative to follow that principle, but it is so logical that it's likely to be a correct approach. So this is after placing my ceramic overlays, lithium disilicate, pressed Emax and not CAD-CAM, because the CAD-CAM is significantly weaker than the pressed material. And now we move to the premolars. So now this is a very important question. Which material to use? The amount of tissue missing is relatively low. I need to restore volume. I need to restore the contact. Should I go with more indirect restorations? I don't think this is needed. It's so simple. It's so effective. Also going nowhere. I don't even need to make any finishing line. Just sandblasting, etching, one increment of composite. And we are done. It's done in 5 minutes. Now you might think, okay, what about differential wear? Yes, that's a fact. What's going to happen? We'll get a little bit of passive eruption. It's sort of a delayed Dals concept. And further in time, since I will restore from second premolar to second premolar with direct composite, if I'm losing a little bit height, I can just remount my composite restorations, I don't know, in 6, 8, 10 years time. And then, according to the Dals concept, I will let the molars just super erupt passively until contact is being reestablished. That's the Dals concept that has been really evidence-based through many clinical trials. So this is not really an issue to use a combination of material. This is what I call a hybrid selective treatment approach. look at the situation. We just need to build up the facial. And composite is not such a weak material. It will be here mainly submitted to compressive forces. You'll basically never observe any chipping, any fracture, very, very rarely. Only in case of very severe parafunctions. It's not the case here. She's not a super heavy bruxa. So this approach, I think, is very safe. And to be honest, I've been using this protocol now since 25 years, and I've never seen any major problem with it. And when I'm saying major, I haven't seen really any problem. I've seen more problems with severe complications below or underneath indirect restorations to be true. So now this is the final view of both lower sextants. And I'm ready to start with the build-up of the lower front teeth. It's already prepared. It's prepared for my adhesive procedures. No prep, just additive procedures using adhesion. So you see here, you see basically the extent of my composite correction. Now I need just to clean the surface with a micro etcher, sandblasting. We use just normal aluminum oxide, 25 microns. No need to use the material which is needed for silicoating. When you sandblast natural to structure, don't use these very expensive materials. Just use regular alumina oxide, because you only want to clean, to take away the aprismatic enamel, take away the hypermineralized dentine surface. That's all what you want to do. But you don't do silicoating on natural tissues. We have the index from the wax up. I will use here the shell technique with the flowable shell technique. I use a super thin layer of flow on the lingual that will serve as a support for my dentine and affects shades. It's nearly like a matrix made of flowable composite. So now you see the dentine, and you see also a little bit of white effect shade. It's called ice, because you see the fluorosis. There is a light fluorosis, and we like to get something a little bit opaque. And this is after completing the build-up. I even used a wedge to separate both ventrals a little bit better, because the contact was slightly open at the beginning, and I wanted to create a nice contact in this area. And this is the final situation. Now, you see the amount of augmentation. You see the level of my augmentations on premolars. And now everything was restored from both sides, second premolar to second premolar, everything direct freehand. The beauty of this, it's completely no prep. And from a biomechanical standpoint, that is a very sound principle. Now we come to the very last treatment phase, which will be to replace the upper 6 3/4 crowns. That is basically the amount of tissue which was taken away. I had, of course, to refine the preparations because they were not looking like this, I can tell you. And you understand, it doesn't require a lot of explanation to understand the difference you have between a no prep approach and a prosthodontic approach. It works. We have been very successful with some of this prosthetic work, but you understand that this is not the right rationale. You cannot treat tooth wear by using such aggressive approach. You can see here the corrections which I did with a direct approach to fill up the corridors to get more volume, and also to correct the inclined occlusal plane before doing the last phase, which are the anterior restorations, upper restorations. What did we do here to correct the asymmetrical gingival profile? There is a coronally repositioned flap here with a connective tissue graft, only repositioning here, and also the bopped technique on the upper left canine. How could I bring the gingiva so much down? That was not only by advancing the flap but also by flattening a little bit the emergence of the tooth. It's a relatively big tooth, and we have enough tissue to take a little bit away on the facial. That will improve the stability, that will create space for the grafted material. This is the final result. In fact, you see the major change in the design of the restorations. The patient went many times to the lab, and she demanded, she did not ask, she demanded more squarish form. She's a very strong woman, very nice one, but very strong character. She hated the round forms, and sometimes patients jump into a completely opposite design. I'm not saying this to hide a mistake into the design of the restorations, because the lab which performed those restoration, oral design in Montreux, Mr. Patrick Schneider, is a top of the top dental technician, and he can do whatever shape is required. But here, there was really the desire of the patient to get this kind of form. So this is just a past treatment view. We have nicely aligned smile line. I just personally don't like the form of the teeth, but it might certainly fit better a male patient. But technically, at least, I think we did really a decent job. You see the behavior of soft tissues. Preparations were clean, impression was good. And you see now on both sides, we only have on the left side still a little incomplete fill-up of the papilla after my surgery, but otherwise the gum looks relatively good. This is only 1.5 years after the treatment, so I think it will further mature until we have a complete closure or build-up of the papilla. This is the final view after 1.5 years. There is nothing wrong we expect after 1.5 years. I personally just dislike the squarish forms, but that was the desire of the patient once again. And this is not to again, this is not just to find an excuse for this, but okay, sometimes we cannot really align the patient's perspective and our perspective. And I would like to share as a conclusion, I would like to share with you a long-term follow-up of the case and to show you when we started this approach, this hybrid approach, selective approach to combine different materials and different preparation forms in order to adapt to the specific conditions of different areas in the mouth. So this is the case which we published in a journal that disappeared from the market since, which was Practical Periodontics and Aesthetic Dentistry. And that was published in 1996. So it's a treatment which we performed in 94 and we completed end of 94 or early 95. So it's basically 25 years ago. This is a bulimic patient. The most severe wear was visible on the lower front, on the upper everywhere, shortened edges, palatal facial. What do you see here? Very, very flat inside the edges. Is it just erosion? No, it's not erosion only. What about the psychological profile of a bulimic patient? Is a bulimic patient a serene person? Not at all. Anorexic patients and bulimic patients are people on very heavy psychological stress. And you can expect that this very intense stress might translate into parafunctional activities. And actually, it is in most of the cases. So it should be wrong to think that here you deal only with erosive pathology. You deal here with erosive and severe attrition pathology. The detail of the facial surface and lingual surface on the lower front shows that we still have enough enamel on the lingual to preserve this part of the tooth and to only restore the facial. And actually, we did only direct restorations. For the path of your teeth, I don't have the time to show you all the details. It's not really the aim. But you see here the wax up made by Michel Magne, amazing work. We had on some teeth a conservative approach, trying to save anyway some tooth structure. You see some little signs of erosion already here. Premolars were more globally affected, so we went with a protective approach. So this is conservative, this is protective. And you see here the models with partial restorations on the upper, partial restorations on the lower. So we started already in those days to do partial restorations, overlays to increase the video. That was made with a material which unfortunately was not etchable. That was Inceram alumina zirconia. That was very strong material, actually, 600 megapascal flexural strengths, but unfortunately non-etchable. So that was a little tricky because in those days we didn't have the products we have today, which we can use to bond zirconia or a similar material if it would still exist on the market. And you see here the restoration after firing and processing on the refractory dies. On the lower front, as I said, we use direct freehand. That was Herculite in those days, a microhybrid. We use a chromatic enamel and incisal shade. It's a little bit more difficult to control the color, but technologically, this material was really already a very good. It was a microhybrid, the first microhybrid on the market, and I would say that proved to be a very, very good material. On the upper, due to the amount of tissue destruction facially, incisally, and lingually, we went with full crowns. You see the type of ceramic work done in the 90s. It was a little bit more chromatic. That was the taste in those days. Now we do things a little bit brighter, a little bit maybe more Hollywood style. This is the final situation. Full mouth reconstruction, combination of bonded partial restorations to elevate the vertical dimension of occlusion. Protective approach on premolars, some premolars, and the front teeth to basically protect those teeth from further erosion. And on the lingual, where we had enough saliva and still intact enamel on the lingual, we used porcelain, direct composite, to restore those things. You see here my composite restorations during an interval of 7 to 13 years. We managed to maintain those composite restorations for 13 years before we replaced those restorations with here feldspathic porcelain veneers. That was the choice of the patient in those days to get the most aesthetic material. Maybe that was not the best choice, but anyway, 7 years later, we replaced everything with lithium disilicate. But the reason to show you this image, this is after the preparations. We are still nearly everywhere on enamel. We could maintain all the enamel which we had at the very beginning with our direct composite restoration for 13 years, which is a very good performance. Now we are at 20 years. 20 years later, what is the situation? We had a non-stable occlusion because the deep bite worsened over time, maybe as due by some loss of vertical dimension in the posterior areas due to very high forces. The patient has never been able to wear a night guard because she pretended that she would vomit even more. You see in a slightly open position now our veneers. We had also a little bit of tissue recession, so we have discoloration of the margins. Some restorations were replaced. They were initially partial ceramic restorations. They were replaced by full crowns because some failed. You see the discoloration. Even ceramics do age in such a critical and stressful mouth environment. Don't think that ceramics will last for 30 or 40 years. It won't. So composite, maybe with a little bit less extreme cases, last easily 10 years. Ceramics will last here 10 to 15 years at the most, because many restorations were changed in the interval. And it shows that more invasive procedures, supposedly stronger materials, will not solve all the problems we have. And there is some literature, I don't have the time to share more about this, but the literature has shown that failures with more invasive restorations are more dramatic. Now, this is a situation in 2019 after we have retreated the patient completely. You see now the upper front, it is all lithium disilicate, monolithic, of course, no aesthetic veneering in this case, it's just stained and glazed. Of course, it's not as beautiful as veneered restorations. This is the lower front. I think this is very decent work. We could bring the new margins to meet the gingival tissue so that we don't have stained margins. But I would like to share with you now the black and white about the case. And what you see here is that apart from that tooth, which was periodontally compromised from the very beginning, we lost 2 teeth due to first loss of vitality, and actually we lost vitality on another tooth in the same quadrant. Even though my prep were not so aggressive, depends very much on the pulp biology. Some patients support full crown preparation with no biological consequence, and some others, even though you prep all the way with water, you try to be conservative. You seal the dent in with your adhesive system, you can still experience some endodontic complications. So it went first through endodontic complication and then finally through vertical root fractures. But here, this patient is a heavy bruxer with no night guard. I'm not saying that it accounts for any kind of complication, but remember that if you go with more invasive procedures, you expose yourself more severe complications. I know that on a case like this, if I would have used only additive procedures, like we could do on some of the teeth, we might have never ended up with so many rather severe complications, even though at the end of the day, if you look at the smile, that looks good. But here I had to do a sinus lift. This is complex dentistry. And if you start too early with this kind of therapy, knowing that it will be repeated at least 2 times, possibly 3 times over a lifetime, this is an enormous amount of money. So my message as a conclusion is be conservative, be first preventive, then interceptive if you miss the chance to be just preventive. Continue your preventive work together with the interceptive approach and try to avoid this kind of dentistry as long as you can. Maybe you won't be able to avoid it forever, but if you can bring such a case further with no complex restorative work, I think this is really the best you can do for your patients. And if by lack of chance, you implemented the interceptive strategy in a patient where it's not good enough, then you know why you need to go with the restorative approach, with CAD/CAM or indirect restorations. But you have made the proof that the simpler interceptive approach was not effective enough. And that is actually my conclusion for these webinars on tooth work. I want to thank you so very much for your kind attention. I hope this presentation, especially the last one, I think will generate even more questions than the previous webinars. So we'll have a short break. We'll leave the Odexcellent team to get ready for the Q&A session. So see you in a few minutes. Thank you again. It's good that this little light, huh? See? Okay, it's giving a much better image than the other times, in fact. I will see the new panel that I bought, but the new panel is to be used for. Okay. Good evening, everyone. It is a pleasure to. It is a pleasure to. No occlusal adjustment video explanation. Okay, sorry, I was just reading the question. So first of all, welcome everyone to the Q&A session for this third part, for actually the last part of the webinar serial on toothwear. So thank you for joining the Q&A session. The first question is from G. So good evening, no occlusal adjustment video explanation. It was the question about getting a video. Actually, I don't have such a video. I didn't have any opportunity to do it since, but I will just try to in fact give again a few words of explanation in regards to occlusal adjustments. The reason for having a wax up is, of course, to gain precision in the procedure. You have seen that was on the first, no, it was on the first or second webinar. Now I'm not sure anymore. We have some diagrams showing that we fabricate an anterior index at the new video, so that before you will place the rubber dam and before you start the build-up, you will have a visual control, a visual assessment of the space that you want to create. Then what will make it rather easy in regard to occlusal adjustments is your ability to replicate the anatomy made by the dental technician or by the software in case of digital wax up, to transfer this information to the mouse. And of course, this requires a little bit of training. Otherwise, as I said, I think during the last Q&A, we don't aim to create tripodic contact. Forget about gnatology principles. They're no longer valid. It's not because you get tripodic contact that this will change anything in regard to the evolution of the case. So you try to get a couple of stabilization points for the occlusion, basically on the facial cusps, as we do most of the time, the build-up on the lower arch, and some stabilization points into the fossas. Again, if your anatomy is well done, we shouldn't get major problems, major troubles in creating a stable occlusion. Then the teeth will undergo micro movements. So this equilibration will be performed over 2 or 3 sessions. We do an immediate equilibration after finishing one arch. Remember that patients have muscles tired, so it is not the right moment to do sophisticated equilibration. It is impossible on this day. So then we'll normally do it a second time, normally about a week, 10 days after the treatment, and normally a third one, 2-3 weeks at the time we do the impression for the night guards, since the majority of patients will receive a night guard. But there isn't anything special in regard to occlusal equilibration. I don't think it is a central, but I understand it is important that you end up with the best possible occlusal balance. But remember 2 very important points. Occlusion has no correlation or is not the reason for parafunctions. You need to regard occlusion. This is the modern view on occlusion. Occlusion is a way to create even contacts in order to avoid stress accumulation on some teeth or some restorations. But whatever occlusal scheme, that will not change the fact that the patient has or doesn't have parafunctions. The only thing is that if your occlusion is not equilibrated, is not balanced, you will have concentration of stresses in some areas. But we need to step back a little bit from the gnatology point of view that occlusion triggers parafunctions. And composite is a wonderful material because even if you don't equilibrate in a perfect way, the material will wear off where you have higher stresses, which cannot happen, of course, with ceramics, or at least not in the same way. You might more get movements, sort of micro-orthodontic movement, where you have higher stresses. So I'm sorry that I cannot illustrate in a more detailed way. For me, it is not a major. I'm not saying that I don't consider this as a part of the treatment, but I think it is not the most crucial step of the whole principle. But if I ever have the opportunity to do a little video, now my headset camera doesn't work anymore. We just changed the computer, so I won't be able to do it right now. But I just remember the question and interest for that. And if I had the opportunity to videotape one case when I do the occlusal equilibration, I will be happy to do it, and then to get it on the EduDent webpage, so or on the Instagram account. So, but thank you very much for reverting to this question. I hope I have been able to give us some sort of a frame around this point. Okay, so thank you, George. I think if I remember well, this is George who asked the question. So we wait for the next question. Question from Ralu. Good evening, Ralu. Thank you. Happy to know that you could follow the explanation, so that it was easy to understand. The question of Ralu is the mezzanine and whether the wax-up model needs to be isolated and how, I guess. Thank you for the answer. Needs to be isolated. I don't know what the mezzanine has to me another meaning. Maybe it relates to the tray for the molding, the full molding technique. Normally, if you isolate, you don't need really to isolate the model if you do the relining on the wax up, but if you do it on the duplicate, which anyway I don't really recommend, or on a resin model, it's better to isolate. You can use Vaseline or any sort of lab isolation material. It depends. Sometimes there are small interactions between more, not the model and the silicone material, but if you use an adhesive that we normally place in the tray for conventional impression, silicone impressions, sometimes the adhesive can interfere with the silicone, the setting of the silicone, and creates a chemical reaction, and you have full of microbubbles. And on top of this, it's staining the silicone material. So that's why we have tried to avoid using adhesives lately, and we sandblast or we roughen a little bit the tray just to get a little bit of micro retention. And that has worked a little bit better than using adhesive. It really depends on the brand. So this is the point. Maria Nikita, thank you for the answer. Okay, now there is another question from Maria. Good evening, Maria. But actually, it was the same. It was the same question. So I hope, Maria, that I have answered your question and I understood the translation in a correct way. Okay, the occlusal guide. Okay, I trust that we refer here to the tray, the hard tray that we use then which is reliant on the model, on the wax up or the printed model. The material, the system which we use is from the Ercodent company. Ercodent is a company fabricating machines for heat forming, and they have a large number of materials which you can heat form. The one which we use is called Ercodure. Ercodure, and this is a hard plastic, and we use at least 2 millimeter. Don't go maybe further than 2 millimeters because it's getting very, very hard, and it's difficult even to take it out of the duplicate. But the 2 millimeter is thick enough, rigid enough, so that it doesn't deform too much when you press the tray, the relined tray on the teeth for the molding. But don't use something softer. That's why also I don't like so much the Muir silicone, translucent silicone material, because when you exert pressure, it tends to deform. So then the only solution is to use a rather soft composite, with a low viscosity, or to heat up the composite. But you need really to use a very soft material. With the full molding technique, we use heated up composite. And since the tray is quite stiff, you don't need to go with the super soft composite. You just need to heat up the composite, and it goes slowly in. So I think it's a very good method. I would say from everything I could try so far, it is the protocol that worked the best in my hands. There are variations about this. There are people who are drilling holes on the tip of a few cusps, maybe one cusp per tooth, so that the composite can come out easily. I've seen this. That works well. Depends a little bit on the stiffness of your material. If your material is really very stiff, maybe that is a very important technique. If you heat up the composite, so far I haven't got really much problems. Thank you very much, Raul, for your question. I hope I answered it in a correct way. Jarino, good evening. Okay, so I think I mentioned this a few times, not only once, a few times over the three webinars. My preference is MIP, maximal intercuspidation position. In fact, once again, maybe let me revert to the different options we have. I would say by today we have mainly 3 options. The first one is the classical centric relationship, something that we needed to understand by today, and there is the whole literature basically will back up, or does back up what I'm saying now. Modern literature, let's be clear. Modern literature about not edentulous patients, but dentated patients. The CRP is not necessarily the best position because it's not a neutral position. It's not a muscular neutral position. It could be rarely, but it's most of the time the MIP. The MIP is anatomically and in regard to the muscle balance, it's probably the best position to use. Having said that, we know that the patients might have a different CRP, and in this case, you might try to check the CRP and see whether you need to adjust interference from MIP to CRP. But today, there is no scientific and even clinical rationale to use CRP as long as you have an existing MIP, which seems to be correct. One exception, though, are patients who went through complex auto-surgical procedures or treatment, because in those cases, the dental relationship, the new MIP, might not be, let's say, a stable position from the TMG perspective, and even from a dental perspective. but okay, the teeth, they need to find pretty much a certain balance, a certain stability. But we might be in a completely unbalanced position, not always, but it might happen that we are really in a completely unbalanced position regarding the TMG. But I will make an exception about this. So I don't want to take this as my main reference. And what seems to be more and more a position that we try to evaluate is something in between the MIP and a neutral muscular position. And that might bring us most probably a little bit more forward rather than backwards. So there are a lot of teams working on this neutral muscular position, which is a sort of new MIP, but MIP is more a dental, anatomical, stable relationship, the muscle stable relationship. But we might find even another position, which is from a muscular standpoint, even more neutral. But then you need to change the anatomy. So if you want to choose this position, of course, you will need to adapt the anatomy of teeth in order to bring the teeth in that new position. There isn't at the moment a very strong evidence regarding how we establish this neutral muscular position. There are different devices, there are different systems to basically, which goes from very simple procedure like biting on cotton rolls, then the patient is standing up, is walking a little bit around, doing movements, biting. It's in a way to neutralize somehow the muscular activity which brings the patient always in the same MIP, trying to find maybe what is a more neutral position from a muscular standpoint. There are also some devices which electrically activate the muscles, somehow tire the muscles in order to find this muscular, or basically not tire, try to erase the automatism that bring basically the lower and the upper arches together in the dental MIP, but then to find a position which is again a neutral position from a muscular standpoint. But it's something which is in process. I'm sorry to be a little to go a little bit deeper here, because the advantage of this new approach will be that if we can find a more anterior MIP or occlusal position, that might facilitate basically clinical procedures or the protocol to increase the video without creating too much discrepancy in the anterior areas. And even, as you know, when you increase the vertical dimension, you create sagittal discrepancies and transversal discrepancies, which strongly limits the opening of video when you treat tooth wear. If you can reposition the jaw a little bit forward, then that will facilitate the procedures, and you can increase a little bit more with us having problems, the classical problems of increasing the video. So now, to make a long story short, by today, if you want to stick to a certain evidence, use the MIP, check the CRP and try to equilibrate the best way you can. But the CRP anyway, already this is complicated to find. You can take a device and force a little bit the mandible backwards. But if you use composite, it will self-equilibrate. So don't worry too much about that. You try to manipulate the jaw a little bit more backwards, and that's all what you need to do. If you go with ceramics, but then you need to check things over a few appointments, because anyway you will find a different CRP nearly every time. And what probably will become more evidence in the future, but it's not right now, is a protocol, an accepted protocol to find let's say a more anterior position into a muscular neutral position. Okay, so I hope I've been comprehensive enough to help you make the best decision for that. Okay, okay, now we have a question from Olga. Olga is asking how I will fill the interdental and interproximal spaces so that the composite doesn't penetrate. So then I can repeat what you have seen in the video and also what you have seen on a couple of images. If you remember on the images, you were having something white. This is the Teflon tape that you have seen me inserting with a spatula. That's what we do to bring basically this Teflon tape below the contact. That is especially necessary if you have maybe not young patients, but adult patients or elderly patients with open embrasures. If you have lost a little bit of soft tissue volume, then it's very helpful because then you prevent the composite to flow and come below the contact. So that's the first area that we need to isolate. The second area which we want to isolate is the proximal contact. How do we do that? The material that I've been using up to now, I still have enough of this material. In certain country, it has been withdrawn by the company Kerr Have. This material name is Rubicep. Rubicep is a latex material, latex-based material. It's like a paint. You have seen on the video, but it was going relatively quick, a little drop, white drop, that I'm just placing just in the contact. It flows, then it's drying, and it creates a physical barrier to the penetration of the composite. What we tried, and I think this works, if you cannot find a similar material, the Rubicep is still available, it's still on the Kerr catalog, main catalog, but you might not find it in every country. Cut the Teflon tape. Don't use the whole width of the Teflon tape. You shorten it and you pull it over the contact. And with a very fine spatula, you push it a little bit. Of course, don't leave the Teflon tape go over your occlusal surface that you want to restore. And that might serve, and then you bring it below the contact. We tried this in one of the last workshops we did, and it works too. I haven't documented this because honestly, the Rubicep is easier and quicker to place. But I think as an alternative, Teflon tape is something that you can find everywhere. You can isolate with Vaseline or something else, but it might not prevent physically a little bit of composite penetrating to the contact. So I would say a thin part of the Teflon tape, just to push it at the entrance of the contact, and then some more Teflon tape below the contact. And a last element, very important, you have seen, I hope, the contour of the tray so that you can go with an instrument and take away the excesses. Those small details are very important because it makes the difference between a technique that will work wonderfully well and a little bit of a mess. So it is important that you pay attention to those details. And if you pay attention, tell the technician to respect strictly those many different steps, and that will work beautifully well. Okay, thank you very much, Olga, for your question. Okay, so question from Yoge, I guess. Yoge is confirming that I recommended 60th splint night guard. Do you preheat the composite before placing it inside the tray? Yes, actually, I preheat the composite before placing it in the tray. What is the name of the tray material from the molding technique? This is what I said before. This is the Erkodur, Erkodur, and I'm using the 2 millimeter thick. So it makes a quite stiff and stable tray. Okay, that is the second part of Georgia questions. Third question of Georgia, if I use a hybrid technique and want to place composite overlays mixed with direct composite, when will you use this approach of composite overlays and why? Well, that is a question. That's something that I didn't touch during the webinar. Which is the best material if you go indirect? Because indirect, of course, is also indirect composite is also an option, like CAD-CAM composite or lithium disilicate. I think by today, if you want to go indirect or CAD-CAM, those are the three options which you have. The advantage of using indirect composite, if you go now full composite, direct, indirect, is only in terms of simplifying your protocol. That you say, where the reconstruction is more complex, I go indirect because it's going to be easier. So the decision will be based on the volume and the extent of your two-square correction. But in terms of behavior, I don't expect any difference between classical or indirect overlays and direct overlays. You might expect a small difference between CAD-CAM overlays and direct overlays or direct build-up. The fracture toughness of CAD-CAM materials is higher, but my experience, to be honest, the difference is not that spectacular. There is a difference, it's better, there is no discussion. But when you do the effort to go with indirect or CAD-CAM, I would probably find the Emax lithium disilicate as a better choice, because it is closer to enamel in terms of stiffness and stiffness, E modulus, and that will grant, of course, a very stable occlusion. But I'm not saying that CAD-CAM or indirect composite is a bad solution per se. I would only maybe recommend definitely Emax for cracked teeth, mesodistal crack tooth syndrome. Non-vital teeth, don't go with composite for non-vital teeth. It's not a good choice. It's not the best choice. I'm not saying it's not the best choice. And if you have very limited space, you will anyway get more success if you use lithium disilicate rather than composite. Okay. So the last part of the question, which platform can I use? Find the literature to support what you just teach us. Let me try to give you, first of all, you can find already some literature, not comprehensive literature, on the articles that I published that you can download on my website. You can just Google Didier Dietschi and you will find my teaching platform, and you can download. There are already a couple of articles on two-square. I've done already a large part of it, but I'm hoping to be done early next year with a book on two-square, which will be quite comprehensive. It's going to be a big one, but I'm not saying that you will have the entire literature, because we can never put everything which has been published. But that will be also a good source of information. But if you look for more information, I trust you know the platform PubMed, PubMed. It's the largest medical platform or literature platform for medical professions, including dentistry. You can select dental literature. You have different options, different menus. And you can say, for instance, if you want to know a little bit more, start first with literature review and two-square. and that will give you a lot of references. The only problem is that you don't have access to a lot of full articles, but some journals will provide the full articles free of charge. Some others you need to pay. You can also, when you have identified the papers which you think are appropriate or are useful for you, you can always go on Google. You copy and paste the full article name, and next to it you put PDF. And if the PDF is available freely somewhere on whatever other platform, you might be able to find it. Not necessarily through PubMed, but you might get it through another platform. Because there are so many platforms, it will be very difficult to find one that will necessarily provide every reference. PubMed is the largest one. Basically everything of quality published today in the dental literature, you can find on PubMed. At least you have the abstract. But depending on what you look for, it's good to have the full article. So remember PubMed, and if you don't have free access to the full article, try to go on Google with PDF at the end to see if the article is available somewhere else. I hope it's a good reference. And in the meantime, you can already get some references in the articles which you can find on my platform. Okay, thank you very much for your interest, George. Really appreciate. Good evening, Christina. The question of Christina is the following: when increasing video, are you restoring occlusal upper and lower on the first appointment and incisors on different day? Is next day appointment okay, or patient needs longer gap to adapt to changes? Very interesting question, Christina. So my protocol, when I go normally, whether direct, molded, indirect, is to do 1 arch per day, okay? I rarely go upper and lower unless it would be a very simple case. It's a really limited tooth wear, and that I think that I possibly could do everything in one session. Your question somehow has already provided part of the answer. The problem is when you want to equilibrate patients with attrition and parafunctional activities. There are patients who relatively often get quickly tired when you make them or you force them to stay open for a long time. So you can use something to stabilize. So you open and you place a plastic. I don't even know. It's not a mass opening device or something like this. It's more something on which the patient can bite so that he doesn't need to keep the mask open actively. That will help. But even with that, the muscles get tired. And when you try to get the patient closing left, right, forward, it's very difficult to get the patient finding again his MIP. And with the difference they feel in terms of occlusion, probably the feedback is not anymore the same feedback. So it makes it very difficult for adjusting occlusion or equilibrating occlusion. So that's why I normally limit the work to 1 arch. Most of the time, I go with a 2nd arch on the 2nd day. And the night is usually enough for the patient to recuperate. From my experience with the patient, if I have some experience with the patient, I might go with anterior teeth on the 3rd day, or maybe I'll push it the next week. If you have the chance to be a little bit flexible, I would maybe try to wait 1 day at least before I go on with the front teeth. Again, it depends a little bit on the type of case. If it's a simple case, when I'm saying simple, understand limited tooth wear, I think you can go 1, 2, 3. 1st day, 2nd day, 3rd day. If it is a more complex case, maybe you give a little more time for the patient to adjust. And then you give also time when we say to the patient to the muscles to adapt. You probably heard about neuroplasticity. There is some direct muscular adjustments, but this is anyway governed by the cortex, neuromuscular cortex, that will coordinate the action of muscles. And we have immediate adaptation, and neuroplasticity is taking place over longer period of time. And sometimes it takes a couple of days, couple of weeks, couple of months, even sometimes, for the patient to adapt. And some patients do not adapt. Neuroplasticity doesn't allow the same degree or the same extent of adaptation in every patient, unfortunately. And these you can only find over time. But I think that, again, depending on the extent of corrections, giving a little time to the patient to adapt is important, as well as leaving the muscles to basically to adapt, and also to be able, very simply, to be able to make some equilibration, that the patient can find the position. Because when the patient doesn't find his position anymore, again, because of let's say the change is destabilizing the balance, the muscular balance, plus the fact that the muscles are tired, makes it sometimes nearly impossible to provide any stable occlusion. And then, of course, you need to postpone the equilibration. So you are just relying on the precision of your work. If it's indirect, normally you shouldn't get too much problem. For direct cases, of course, you need to equilibrate, and you want the patient to be able to close pretty much in the same position. So thank you for the question, because it is very important. It is a very important aspect of the technique, especially for the direct options. Okay, thank you, Christina. Okay, now Yvonne. Good evening, Yvonne. The question, Yvonne, is to know whether we can conclude that the therapy, direct, indirect, or hybrid, will depend on the erosion and not the age of the patient. And when do patients drop bruxism or clenching? What has been your experience with the evolution of parafunction? Thank you very much. So let me maybe reply the second question, Ivan, because it brings to a very important point. When you see the patient for the first time with evidence of tooth wear, first of all, we can somehow understand what happened in the past in regards to the type of lesions we observe. So we have typical lesions for erosion. We have wear facets, which are anatomically completely different for attrition. And we have these combined cases. That was the information which we discussed in the first webinar. But this is actually what you observe when the patient is on the chair, is the past. We have no idea what's going to happen in the future. Depending on the age of the patient might have gone through a very stressful period, which might have bring him to have unbalanced diet, maybe a little bit of reflux, or more reflux, and also parafunctions. If the patient has returned to a calmer life, parafunctions might be less, because parafunctions are partially triggered by stress, anxiety, and being tired, and depression, and many other psychological factors. Not only sleep bruxism and awake bruxism. Sleep bruxism is considered a sleep disorder, but we know by today it is connected to the degree of stress and anxiety, and again, some psychological factors. Awake bruxism is as well. So we don't know. We don't know what the life of the patient will be in the future. Diet, hopefully we can help the patient to control diet, but as we know, diet, unbalanced diet is a common element, or is usually related to some sort of psychological stress or disorder. So in fact, it's very difficult to predict, because what we observe is the result of what happened in the past. And this is why, and thank you for the question, because this is why it is so important, whenever it is still possible, to use composite, because the composite will be used also during a testing phase. When the teeth are completely destroyed, of course, it may be not any more feasible to go with the direct approach. But even if your direct composites are not super refined, perfect, but it will protect the teeth. It will, even if it's not perfect, will create a more stable situation sometimes, and it will give you the chance to monitor what happens, monitor the evolution of risk factors. Where do we stand today with the risk factors? And by talking with the patients, you might usually not get all the answers. It's very difficult to capture the whole information, and to get the whole information, extract this information from the patient, because patient might be reluctant to tell you their entire life and the reason why they are stressed. You might find out over time. So you're absolutely right. Very difficult to predict, and I think there is no way we can predict. The only thing we know is that parafunctions are rarely disappearing completely. Even if you get quieter, if your life is getting quieter, it seems unlikely that parafunctions will drop to zero. We spoke in the last Q&A, we discussed the buttocks treatment. Okay, the buttocks is a way maybe to get a sort of stabilization, but this will not impact the trigger element, which might be the stress, the psychology, and anyway, what happens at the level of the central nervous system. But at least at the level of muscles, we can reduce the forces. So we don't know. We cannot predict using composite, or for very early stage of tooth wear, night guard will be a way also to see what happens. And occasionally I'm telling the patient, look, because patient says, I know I was bruxing, I had problems with erosion. Today everything is solved. Then I'm telling the patient, okay, let's do a night guard that you wear for a couple of weeks, maybe up to 2 months, 3 months, and then we'll see, because you don't need years to see if the patient is still bruxing. So we might use a night guard, even if we know that we're going to treat the case, but just to evaluate what is the status with parafunctional activities. So now, to come back to your first question, the choice of the therapy, direct, indirect, or hybrid, you're absolutely right. It depends on the severity of tooth wear. We also know that tooth wear might affect certain teeth more than others. So we might have reasons to use ceramics in some other places more than in some other places, because of functional forces, but also because of the amount of tissue missing, or because of the biomechanical status. If you have a non-vital tooth which was not restored properly, it means just have a filling, nothing, no occlusal coverage. If you really have sign of heavy clenching with the teeth with a very concave anatomy and not so much space, maybe a ceramic overlay is the right thing to do on those teeth, rather than to go with direct composite, because direct composite in clenchers where you have thin layers doesn't work so well, because also during the day patients don't wear a night guard, and they might wear off the composite much quicker, eventually create chipping or little cracks. So it's in fact related to the extent of tooth wear, but also to the forces. So that's why understanding how to treat tooth wear relates, of course, to the risk factors, to understand the different protocols we have, because again, there is no monotherapy for tooth wear, and also understanding biomechanics of the patient, trying, because it's not easy to understand everything, but by observing the lesions, the teeth affected by tooth wear, you might understand quite a number of things. Not everything, but many things. So forces, space, which is related to the extent of tooth wear, are normally the elements which will guide you toward using a stronger material, even if it's indirect, or something a little bit easier, simpler, and more cost-effective, which is the composite. Thank you, Ivan. Very interesting questions. Okay, question from George. Do you have an online masterclass as the one you offer in your workshop in Switzerland that explains step by step about molding techniques and occlusion in live video explanations? How much was the temperature used to preheat the composite? I answered the second question immediately. I normally preheat at 55 degrees. So when you inject, of course, the material is spreading faster and it will slowly cool down. But at least we don't bring the material at 20 degrees. If you're in summertime with air conditioning, the composite might be even lower. And if you go at 18 degrees in the mouth, it will take a little while for the composite to warm up. When it's heated up, you place it at 55 degrees. It will start to cool down a little bit, but it will probably still be 35, 40 when you get in the mouth. And it's really helping you. It's more comfortable to place it. Some heating devices, they can heat up at a higher temperature. Some go up 65. I think when you place it in the tray, even if you go, well, mine doesn't go at 65, but if you go at 65, you can possibly use it because it will cool down anyway before it will be in contact with the teeth. So online, unfortunately, Georgia, I don't have for now. I don't think that I will do it in the short term. That was a project I had to do a full master class with the live demonstration, actually, step by step, so that it's really you can see every single detail of the technique. But in fact, I have already so many requests for the presential. Let's stay connected. I'm not going to do it right now. I'm not saying it is impossible in the future. I mean, I'm getting a lot of requests, so it might happen, but not right now. Sorry for that. But thank you, George. Thank you for your questions, because you are a great. You really interacted very positively with me during those 3 webinars, and I really appreciate very much. Excellent. Christina, good evening, Christina. What if patient can't afford full mass reconstruction of occlusal wear? Would you restore just anterior aspects and provide NADGARD to stabilize situation? Well, Christina, this is it is a central question. Your question is a central question. In a perfect world, like we might think there is everywhere, like on Facebook, you see so many amazing cases on the internet, on Facebook, on Instagram, sometimes in congresses about beautiful 28 CAD/CAM or pressed ceramics with top photography. It's amazing. It's inspiring. But we know that for the majority of patients, this kind of work is out of reach. And even when we go with composite, if you go right away with the full mass rehabilitation, it takes a minimum amount of time, and that might exceed the patient's financial means. So you're absolutely right. What you describe actually is the DALS concept. I trust you all heard about the DALS concept. The DALS concept was originally an orthodontic approach for deep bite that might have been over time been used more and more for tooth wear, restoring the front teeth only and leaving the back teeth to supra-erupt. So there is a combination of intrusion, passive intrusion, and extrusion. It happens depending on the amount of space you create on the back teeth over 4 to 10, 12 months. Teeth might supra-erupt. If you use a night guard, you might somehow block the back teeth to supra-erupt. If the back teeth are being worn down, your suggestion is absolutely correct. You don't want to restore the front teeth, leave worn part of your teeth without protective material, because otherwise you will lose the space which you created by doing the front restoration to also restore the back teeth. So if the idea is to postpone the treatment of back teeth, you're 100% right. You do a night guard to block the back teeth. The only thing with that option is that the patient will remain with no posterior occlusion until you can finally deliver the posterior teeth, but the posterior restoration. It is definitely the best protocol, but the DALS concept, since you have very, very, very few cases where you have worn anterior dentition and nearly intact posterior dentition, that normally only happens in one situation. For me, there is only one indication for the DALS concept, or the major one in the context of tooth wear, is deep bite and bruxism. With the deep bite and bruxism, it is one of the case I have demonstrated during the first webinar. As soon as the patient is moving, you have disclusion of your path of your teeth. And that's why you have nearly no attrition, if you have no erosion, and if it's only a patient with parafunctional activities, you will have only wear on the front teeth. So then you can do a sort of DALS concept, and you leave the back teeth to return into normal occlusion, which normally happens within 4 to 12 months, broad range of adaptation. And this happens in about 80% of the cases. Not every patient will respond to the DALS concept, but be sure that you don't apply the DALS concept to patients who have worn part of your teeth, because then you have no space anymore to protect their teeth. And I think that's why I'm always saying the DALS concept has very, very limited application to the treatment of part of your teeth, unfortunately. But when it is the right indication, that's an excellent concept. Thank you very much, Christina. Those were very good questions. Last question from Georgia. Then you are closing the discussion, Georgia. No, sorry. The question was from Georgia. Okay, so then I think we've got the same question not from Georgia, but it was from Christina. So I don't know if Georgia was having another question, because actually this is the same question which has been repeated now from Georgia, but I guess it is another question. So, okay, I don't know what accident. Last question from Georgia. Can you get the question of Georgia? I trust it was another question from Georgia that It was not the same question as Christina. Okay, here we go. Okay, that's very good. That's very good. So the question, if Georgia, is if I can summarize, in fact, to get information about the difference, how we can identify the difference between bruxism and clenching, and how whether your treatment approach might differ accordingly. This is very good. This is very good. It might refer also to terminologies, and people might have a slightly different understanding or meaning when we say clenching and bruxism. Some people bring everything together, that bruxism is equal parafunctions. I personally make a distinction between bruxism. I understand that clenching is a peculiar form, or is a subtype, if you like, of bruxism. But I personally consider that we speak about two different phenomena. And it's very simple also to recognize in the mass. Clenching means the patient is closing and basically stays in the contact, creates a lot of force with very, very small excursive movements, or nearly no excursive movement, nearly stays in the same place. That creates completely different lesions from the bruxism. Bruxism, you have excursive movements which go far. Usually and you have different type of excursive movements, mainly protrusive, mainly lateral, and combined excursive movements, which are lateral protrusive movements. The main difference is not only the fact that the patient is moving more or less his or her teeth, but the type of lesion is completely different. When you get bruxism, you have normally wear facets on the canines and all the front teeth, which create the anterior guidance and the canine guidance. So you have flattened canine tips, you have flattened inside the ledges, sometimes both upper and lower, but very little bit of wear facets, because more anterior guidance you lose, more you try to get group guidance. Then you progressively get also wear facets, but mainly on the cusps. The difference with the clenching, you get very concave anatomy, and a lot of the wear occurs in the fossas. Of course, you have a little bit flattened cusps, but you have this completely convex anatomy, which is completely different. It's really a different scenario, not only from the forces and the type of occlusal contacts which created by clenching or bruxism. So it is, there are different type of movements, and the clenching is more detrimental to the material than bruxism. Bruxism, you can reconstruct your anterior guidance with composite, and you will be in relatively good control. Even direct composite works relatively well. Clenching is, for me, the limit for composite, because in these very concave anatomies, it's usually difficult to reconstruct a very thick volume to use a thick volume of composite. If you want to restore the anatomy, you will always end up with, anyway, relatively thin layers on the second and the first molar. And this is for those cases that I normally use relatively often lithium disilicate, and the rest I do with composite. In bruxus, I might do more with composite. If I recreate a good canine guidance, that will reduce shear and tensile forces, because I don't have too much lateral contacts on the posterior teeth. And anyway, normally the posterior teeth show less wear than in case of a clenching. And remember, you might have erosion and attrition. and you have patients, they clench during the day and they brush during the night, or they might anyway do both simultaneously, either at night or during the day. There is nothing standardized in terms of tooth wear. Patients, they only brush, some other they only clench, some they clench and they brush, and on top of this they have erosion, which is making everything even worse. So the very last question, not a problem, from Georgia. If I treat a patient with moderate tooth wear and I would like to perform a bridge with overlay preps, not conventional preps, and cement lithium disilicate, will it be possible? Yeah, I think it's I have done a couple of inlay overlay retained bridges. I would lie if I would say that I didn't have any breakage. In some patients, it worked perfectly well. In some other patients, I had cracks. Again, it's very heavily related to function. I have more experience in the past with bonded gold inlays and onlays, overlays, using Formitha technology. That was a special cement, which is not a composite but a resin cement that we're using after doing some tin plating, applying tin plating on the gold, and that was very, very successful. And I've got zero failure with that technique, but it's a very old technique, and of course nobody wants to get gold overlays or inlays to retain a pontic. But it's a matter of getting a connection high enough, and that's why the pure overlay preparation is a bit risky, because if you have a box preparation, Michelin distal of the pontic, that might give you the thickness, or the diameter, the surface which you need for the connection. If you go with the pure onlay preparation again, you might get something relatively thin as connection. And I tried this. I've got problems. When I had the box preparation, then I was getting something much thicker. A couple of cases it worked well, but I would say you can try, but it's a bit risky. It's a bit risky. So thank you, everyone. I really appreciate. Thank you for really the very, very good questions tonight. Your question has been right into the center of the issues and the information that I have shared with you. As a conclusion to this webinar serial or mini series, you understood it is a vast topic. Tooth wear is a multifaceted problem. It involves so many different aspects. My program up to now has been 3 days, starting from next year, but with the COVID, we don't know, but at least in 2022, it's going to be a 6-day program. So much information we need to know in order to manage tooth wear cases, I think, in the best possible way. And of course, over 3 hours, it was a good introduction to the topic, but I appreciate the fact it was not enough to give you the full information. Well, I hope I might see a couple of you once for a comprehensive program. I want to thank you so very much for your kind attention. Thank you to the Otixi team for the wonderful platform, the very kind interaction we had throughout those different webinars. And thank you for all of you participants. Thank you to Alexander for the translation. It has been really a great privilege and pleasure interacting with you all. Have a wonderful evening. Enjoy the rest of your evening, and hope to stay in touch. somehow. Bye-bye.